Thank you so much for the kind introduction. Thank you, Kian, for the invitation. I really enjoyed the symposium so far. And so right now I'll be talking about the protocol that we recently developed. And in fact, James and his lab is collaborating with us on this. And we just recently published this study in Frontiers in Genetics, looking at refining HLA antibody assignment using this absorption and elution technique that we call ACS. So I come from Halifax, Canada, and Halifax looks beautiful 5 months of the year, but unfortunately, this is what it looks like for the other 7 months of the year. My boys are taller than I am, so you can imagine how long it took us to clear all the snow out of the driveway. And so that's only one challenge that we have in Canada. The other challenge is that this is the second largest country in the world. And so for non-Canadians, you see the statistics here. And the population is quite sparse and it's spread across this vast land. And as you probably know, we are sharing organs nationally right now through the highly sensitized patient registry. And when we're going to send an organ from, say, Vancouver all the way to Halifax, where I am, we really want to ensure that all the testing and virtual cross-matching is correct. Because last thing we want to do is to ship an organ and then this organ having to go to an unintended recipient. So we've been doing a lot of work nationally to ensure that the testing is really good. And so prior to 2009, we really only just had provincial transplant systems. And then since 2009, we've introduced some of the registries, and I already mentioned the highly sensitized patient registry and also the kidney paired exchange here, as well as the non-renal waitlist. And that really correlated with improvements in HLA testing. So you see that prior to 2009, we're using serology for the most part for antibody testing and typing, which wasn't giving good results. And certainly you couldn't be doing virtual cross-matching based on that. But nowadays, all HLA labs in Canada use molecular techniques and type for all significant HLA loci. We all use flow cytometry cross-match, and importantly, single-gene bead assay and virtual cross-matching. However, virtual cross-matching has its challenges. It's only as accurate and as complete as the antibody and HLA typing information that we put into the system. The typing resolution can be an issue. There's a lot of patients that have allele-specific antibodies, and if you don't have allele level typing, it's difficult to predict the virtual cross-match. There are some interferences with the test where we can actually miss some very strong and clinically significant antibodies. And we actually all agreed in Canada to treat patients here with EDTA to try to prevent that. And a real important issue is the presence of these denatured epitopes and other artifacts present on these single-engine beads that we use that I'm going to be talking about in a second, that can really interfere with our ability to interpret and predict virtual cross-matching. In fact, often, we can deny patient potential transplantation from perfectly well-matched donors because we don't recognize that these antibodies are not clinically significant. They kind of masquerade themselves as if they were real antibodies. So I'll start with a case presentation to just show some of the issues that we are dealing with. And so this is a 66-year-old female patient who had a previous transplant from a deceased donor, and this transplant now failed, and she's now relisted on a deceased donor waitlist. This is patient's HLA typing, and here we have the previous donor typing that was done by serology because that was in 1997. And so this is the single-engine bead assay pattern for class 1 HLA in this patient. So you see some strong reactivities, kind of intermediate, and then this is starting to get weak. And now the challenge is, where do we call these antibodies are significant, and where do we actually stop calling these antibodies? So one thing that all HLA labs do is try to plot patients' own HLA alleles onto this panel just to give us some idea where their own reactivities are, because patients typically don't make antibodies against their own HLA antigens. So these are highlighted in green here. And then many labs, say in the US, use some kind of a cutoff, so 2000 MFI, to call these as positive, and these are negative. In Canada, we're a little bit more conservative, and many labs will use 1000 MFI cutoff to make this determination. And here's the CPRA, which is panel reactive antibody, telling you how many donors in the population this patient will be predicted to react with these antibodies based on the allele frequency. So you see that if we start calling all these antibodies, we are really starting to limit the ability of this patient to receive a transplant. Now, in this particular case, though, we also have the information on previous mismatched donor antigens, and they are highlighted in red. So you see that calling antibodies using these artificial cutoffs is really not great, because there are some antigens that this patient was exposed to, and they're in this weak reactive range, but we would actually ignore them if we didn't know this sensitization history. And then a lot of labs nowadays use this applet analysis. So applets are these patches of amino acids on molecules that are probably the targets of HLA antibodies, and we can actually perform analysis to see which antibodies or which antigens carry some of these applets, and can we actually make sense out of the antibody pattern. And so when we do this, if you look at the previous donor who was A1 and 11, there are 5 different applets that are mismatched between that donor and the recipient. And if you highlight every single antigen on the panel that carries one or more of these applets, you see that you can probably predict that this reactivity, the real antibodies, are stretching quite far into this range that normally a lot of labs would not really consider as positive. And this is based on the B locus mismatch here, so 2 applets mismatched, and this is based on the C locus. So again, calling based on cutoff doesn't really allow you to see what may be clinical significant antibodies. They're based on exposure to previous donor antigen. However, again, how can we really tell that these antibodies are reacting with native targets and are not simply background reactivity and maybe some denatured epitopes and so forth. Also, with this applet analysis, we cannot explain the entire reactivity. So if this patient was exposed to B49 here, yet with the applets, we are predicting that this B45 and B44, which are a lot stronger, arose from the same sensitization. That typically doesn't make sense. So there's something that is not making complete sense here. So how do labs actually then adjudicate these antibodies? How do we prove that an antibody, that the low-level antibodies react with native HLA epitopes? Well, we can use alternative single-antigen bead assays. There are 2 different vendors that can be used, but the problem is that there are protocol differences. So seeing differences between these 2 assays and say one assay says that the antibody is positive, the other one says it's negative, doesn't really tell us the true picture. We can use alternative solid phase assay. Single-antigen bead assay has antigens that are recombinant antigens, and there could be artifacts based on that. So you could actually use PRA assays, which have non-recombinant HLA antigens. But the problem is that those assays are not granular enough and not sensitive enough for highly sensitized patients to make determination regarding these antibodies. We could also perform flow cytometry crossmatch with surrogate donor cells because obviously the cells, the lymphocytes, will have native HLA antigens. But there are a lot of issues with flow cross-matches. There's lots of false positive reactions. A lot of labs are seeing up to 20% of false positive reactions when there are absolutely no HLA antibodies. And the flow cross-match also, the sensitivity is a lot lower. So some of these weaker antibodies would not be predicted to give a positive flow cytometry cross-match, even if these antibodies were in fact genuine. And then the availability of donors. So if you have a patient that has a lot of antibodies that you're not really questioning, how do you pick a donor that is only positive for the antigen of interest in the weak range that is negative for all the other HLA antigens? That's nearly impossible to find these donors. So now I'll talk about using this technique that we we recently published on called the ACTS protocol to try to refine antibody identification. So basically what we do is we take a patient serum, and then we take donor cells that express one or more or several antigens of interest. And then we react the serum with these cells. And then if the patient, in fact, has antibodies that are targeting these native HLA antigens, these antibodies should bind to the cells. And then we're going to be able to remove the other antibodies by washing the cells. And then after that, we have to save the last wash to make sure that we really washed out any unbound antibody, and we'll use that later as a control. And then we use acid dilution to lift these antibodies off the target cells. and then we spin the cells out into a pellet and collect the eluate. So now, basically, you have a supernatant that should contain antibodies that are really targeting native HLA epitopes on these cells. And now we can actually put this eluate back on the single-engine bead assay and see what reactivity remains. And as I mentioned, we always have to test this last wash control to ensure that all the unbound antibodies were removed by washing. And so we'll go back to this case that I was showcasing to begin with. And just to show you that when we pick a donor that has 3 mismatched antigens, and so now we are interrogating antibody reactivity against these 3 mismatched eplets, we'll see what actually elutes out of these cells. And here's what elutes. So these are the antibodies that are eluted from the cells after this reaction, the AX reaction. And now you can see that we can, in fact, demonstrate that all of these epitopes that we predicted were explaining the antibody reactivity, in fact, are explaining the antibody reactivity, except for this B82 molecule. And turns out that, in fact, there was a novel epitope that was responsible for some of this reactivity that we were able to, a technique that actually wasn't even described before. So this is another use of this technique, is to actually characterize new antibody specificities. And here's another cell, just to confirm that this new epitope was present there. So this cell is now mismatched for the B44, and yet we are eluting the entire 41T reactivity, but also this new, 166DG reactivity. So we've confirmed the new epitope there. And finally, with a third cell, we are able to then demonstrate the reactivity against these 7 other eplets, and it's shown here. And so by performing this AX protocol, we are able to demonstrate that, in fact, this patient has antibodies. They are reacting against all of these kind of antigens strongly, but also against some of these antigens right here. And these antibodies are reacting weakly, but in fact, all of this reactivity is targeting native epitopes and is not just background reactivity. And this is really important then to be able to communicate to the clinicians, because not that we cannot transplant this patient across some of these antigens that the patient is reacting weakly, but the clinical team should be aware that, in fact, these are genuine antibodies, and to be ready to potentially do some desensitization or early intervention post transplant. And then there is going to be potentially a risk of antibody-mediated rejection. So then I'll show you case 2. This is just to show how we can perform eluate with against class 2 antibodies, and how, with a single donor, you can actually elute the entire reactivity. So here is the case again, and with the epit analysis, we can basically show that this reactivity is likely due to a reaction with 4 different epitopes, 70DA for the DR, 55P for the DQ molecules, and these 2 eplets for the DP. And then by picking a single donor that is mismatched for DR11, DQ7, and DP14, we are able to elute the entire reactivity and demonstrate that, in fact, these antibodies were targeting these particular epitopes. And all of these antibodies, even the weak ones here, that in many cases would be not called as unacceptable antigens because they are in this kind of background range, are in fact due to genuine HLA antibody reactivity. And finally, I'll show the third case, and to give you some thoughts of where we think this AX protocol may be really useful. So this is a 59-year-old female patient with previous pregnancy as a sensitization history, and the 2 major mismatch antigens with the husband were HLA-A2 and B44. And as a result, this patient formed kind of weak class 1 HLA antibodies. And then I'll try to showcase how AX protocol is actually better than cross-matching to show, to demonstrate antibody reactivity. So here's the reactivity in this patient in her serum. So you see the A2 reactivity, for example, and B44. So these are husband's mismatched antigens. And these antibodies are pretty weak, running at below 2,000 MFI. So many labs in the US, for example, would probably call these as negative based on the cutoff. And so what we'll do now is we'll look at the cross-match reactivity of this patient's serum against donor cells that are mismatched for A2, A33, and B65 here. So here's the negative control serum, which all HLA labs will use as a basically baseline. And then this is reaction of patient serum against the donor cells that are mismatched for these antigens, as I mentioned before. So this is actually a very weak positive cross-match with channel shift value on the fluorescence scale of 105. And in my lab, the cutoff for where we would assign positivity would be at 70 channels. So it's just a very weak positive cross-match. But when you start diluting this serum, and so now the antibodies become weaker, and you perform cross-matches with diluted sera, you see that already if we dilute this antibody to, or the serum to 1 in 2, the cross-match becomes negative, and at 1 in 4, it also becomes negative. But look what happens when we perform the ACTS protocol testing. So with the neat serum, we can clearly demonstrate that we are able to elute the A2, A33, and B65 antibody. At 1 in 2, where the cross-match was already negative, we still can demonstrate the presence of A2, A33, and B65 antibody. And even at 1 in 4, where again, the cross-match was completely negative, we're able to demonstrate that we're able to elute A2, A33, and B65 reactive antibodies from the donor. So this could be where, this could be a very useful test to not only demonstrate the reaction, the positivity, but also which antibodies and against which antigens they are contributing to the actual reactivity pattern, whereas the flow cross-match cannot really tell you. It's just shifts of fluorescence in the assay. So our next steps are going to be to try to demonstrate that this is actually a more sensitive and more specific assay compared to the flow cross-match, which is not that sensitive and not that specific, often give you false negative and false positive reaction. In conclusion, I hope I was able to show you that the ACTS protocol helps to overcome some limitation of the single antigen bead assay, can distinguish antibodies targeting native epitopes versus denatured epitopes and some non-specific reactivity patterns. And so it really improves immunological risk assessment. You can really improve HLA antibody analysis and confirm and refine epitope analysis and identify new epitopes. And so just to quickly end, and I don't know if any of you know Dr. Duquesnoy, who was responsible for kind of the concept of applets, but this was his idea of how HLA testing and then using the applets evolved over time. I have slightly different take on that. So with the CDC cross-match, you were able to get pretty bulky, but you'll agree that single antigen assay gives us much better definition. And then, of course, the epitope analysis is kind of like a supplement that you have to use with the single antigen bead assay. But if you want to get really good definition without breaking a sweat, then really you need the ACTS protocol. So I'll stop here and just thank the HLA lab in Halifax and, of course, my collaborators, Dr. Sandra Tafulo from Portugal, James Lan, and Rob Carroll, who really contribute to the ACTS protocol study that we recently published. So thank you so much.
Please go ahead.
Hi, Rob. Thank you for a great talk and all the work that you do in this field. I was wondering what your thoughts were on, because right now we're calling HLA antibodies against the whole like A2, A3, things like that. What about like epitope antibodies? Because right now we know that antibodies bind against epitopes. So where do you think the field is going in regards to changing the way we call antibodies?
Right. So again, excellent question. And I think we're conceptually you would want to go and be able to identify the specificity of the antibody and be able to call the epitope. The issue is that applets, which is the main way of identifying epitopes, are actually not perfect. There are a lot of applets that have been identified as high immunogenicity applets that in fact turned out to be denatured epitopes. And so we see examples of that. Also, there are epitopes, as we've shown here by doing absorption elution, they have not been actually described. So often you're assuming that the reactivity that you see is due to certain pattern of effort, but in fact it's not. And we see that quite often by using this ACT protocol, because there you really, you have to be able, you're pulling antibodies based on true epitopes. So we are seeing that epitopes have holes in them, but also you have epitopes that have been, described as genuine epitopes that in fact are not. So it's not a perfect system. So I think we have to do a lot more work and use approaches such as absorption evolution to really identify and characterize epitopes. And again, by using absorption evolution, you will be able to say, yeah, this antibody is in fact targeting this particular epitope, because by eluding an antibody with a single epitope mismatch and then seeing what antigens are reacting, we still now know that this is because of that particular epitope. So I think that's really an important step towards that.
Great talk, Rob. I'm interested in you thinking about the application to class 2. You talked about class 1 for the majority of this conversation, knowing that there's a lot of pathogenicity with class 2. How do you see that now evolving from class 1 into class 2 research and then clinical application?
We can absorb both class 1 and class 2. Class 2 is a little bit more difficult to absorb. We are using peripheral blood cells. And so as you know, class 2 is only expressed on B cells and probably monocytes. And so on this subpopulation of these cells. So we're seeing slightly lower efficiency. We're still able to absorb them, where I think, if you have challenging cases that involve class 2 antibody reactivity, it's probably better to use cells like splenocytes as targets, where there are quite a few B cells there. They have high expression of class 2 antigens, and then we are really able to pull a lot of these antibodies and characterize them quite well. Does that answer your question?
It definitely answers the question. I'm curious how we're going to get splenocytes for this analysis. Are you talking about recipient splenocytes or
No,
just stock?
We are using, so many labs will collect donor splenocytes for deceased donors and actually perform cross-matches retrospectively. Also, some labs will actually archive these cells, they'll freeze these cells. And so now we can envision a repository of splenocytes. And again, when you isolate even from a little piece of spleen, you'll have billions of them. So you can aliquot them into many specimens. And then once you have that HLA typing of this particular donor, you can very easily say, okay, for this particular serum, I need this and this and this antigen mismatch. Look through your database of donors, pull an aliquot, and use that for absorption evolution. So that's where we are using fresh cells in Halifax, but so we actually have a list of patients that we need to absorb, and we say, okay, we are waiting for this particular donor. When a donor like this comes in, we take sera from these patients and just absorb them basically to try to characterize these antibodies. No further questions, and thank you so much again for your participation.